So hi, I'm Pippa Bailey. I'm a consultant senior lecturer in renal medicine at the University of Bristol and a Wellcome Trust clinical research career development fellow and honorary consultant nephrologist at North Bristol NHS Trust. And what all those titles essentially mean is that I'm a medical consultant and spend some of my time working in a hospital, and I'm also a researcher and spend some of my time at the university carrying out a programme of research. So I did my medical training at the University of Cambridge and the University of Oxford, and then carried out my foundation year training in the Oxford Deanery before moving to Bristol for core medical training. I then took some time out to do the Diploma of Tropical Medicine and Hygiene in Liverpool before going to work in Mbarara in Uganda. I then started a renal academic clinical fellow job, which led on to an NIHR funded PhD, which then led on to a clinical lectureship. And having completed my clinical training and become a consultant, I then secured funding from the Wellcome Trust to fund my current position. The first is health inequalities and health inequities, and the other area of interest really reflects my clinical area of interest, which is organ donation and transplantation. And my kind of biggest programme of research to date has been focused on understanding a socioeconomic inequity in transplantation, and so that's where most of my research has been focused. I think one of the great things about this job, about clinical academia, is that there isn't really a typical week, and what I will be doing in my research time will vary depending on kind of what stage a research study might be at. I might be at the point of designing a study and working with collaborators to kind of optimize that study design. I might be working to apply for funding, or undertaking the work, applying for ethics approval, carrying out data analysis, which is one of the best bits, or preparing work for publication or presentation. I might be supervising people, master's students, PhD students. I might be teaching. So that side of my job really varies a lot week on week. The bit that's kind of consistent is the clinical work. So every week I have one clinical day in which I'll be undertaking transplant clinics or living kidney donor assessment clinics or general nephrology clinics with regular transplant meetings and a regular transplant on call as well. When I started, I really started with an interest in renal medicine rather than research. And the reason I applied for my renal academic clinical fellow job was because it gave me the opportunity to secure a renal job. And at that point, I'd just finished the Diploma of Tropical Medicine in Liverpool and was about to go to Mbarara in Uganda and wanted to have a job to come back to. And so rather than having to apply for training jobs when I was in Uganda, I applied for a renal academic clinical fellow job that was advertised just before I was about to leave. And so I really got into kind of renal research because of wanting to do renal medicine. But when I started as an academic clinical fellow, a colleague of mine, consultant colleague, had just finished his PhD. And he had, as part of that work, analysed UK renal registry data, and he described this socioeconomic sort of inequality. So he described the fact that people with kidney disease who were more socioeconomically deprived were less likely to get a living donor kidney transplant than people who were less deprived. And a living donor transplant is really one of the best treatments we've got available for kidney disease. And I remember thinking, well, I remember being sort of outraged, I guess, bothered by the fact that this inequality existed in renal medicine, and that's something that I think is part of who I am outside of medicine. I'm bothered by inequity and inequality in society, and so that's why this sort of area appealed to me initially. And I thought maybe I could start doing some of the research to try and understand this. So that's really where I first kind of became interested in this area, and it kind of combined my two interests, which were transplantation and organ donation and health inequality. So it was just a perfect fit, really. Well, I guess if you speak to any clinical academic, most of them would say that juggling the combination of clinical work and academic work can be quite challenging, because you have sort of two masters, two organisations that you're working for. So for me, the NHS and the university, and both of those organisations will put lots of demands on your time. They will ask you to do lots of things for them, teaching, supervision, contribution to management, governance, that sort of stuff. And it can be quite difficult to know where to spend your time. And I think early on, you can sort of say yes to too many things and find yourself stretched. And so I think one of the challenges is really, firstly, knowing how to say no. And then once you've learned how to do that, what to say no to and what to say yes to. And you have to be quite strategic, I think, in knowing what might be right for you to say yes to, and what might progress your research and maybe your career, and what maybe you should say no to and someone else might be better suited to. Another thing I personally struggle with is the pace of research. So it can take a long time to progress research from your initial idea to actually kind of yielding outputs, results that might then change practice or policy. And it is difficult, I think, when you're in clinical practice, knowing that the research is taking a long time, and knowing that the people who are affected by this research, people with kidney disease, people with transplants, can't put their disease on hold to wait for this research to progress. And so I certainly, along with other clinicians, feel a sense of urgency to get the research done. And obviously it has to be done well and, with appropriate ethical approvals in place, but the process can take quite a long time and it can feel quite frustrating. And I think that, one of the challenges, I think, for researchers is to try and make sure research happens as quickly as possible. And it's recently been shown with the recovery trial that can happen. And so I think, I find it quite challenging, the time it can take to take a research study from idea to actual kind of fruition of outputs. So, the opportunity to indulge in some research and teaching, supervision is just great. So the variety is brilliant. I think the flexibility is also something I enjoy and make the most of. I can work in a way that suits me best. So the type of research I can do isn't reliant on a sort of a certain lab time or anything like that. For other people's research might be, but so I can work in, say, the mornings or late in the evenings when I maybe work best. And that's quite nice to have that flexibility of being able to work when suits me and when is best for me. I think I'm better, in a better position to understand research that is designed to inform clinical practice, and better able to appraise it and really know when and how to apply it to clinical practice. So I think that it's certainly enhanced my ability to deliver evidence-based medicine, and that's sort of as a personal, as a doctor working with individual patients, but also as a doctor who contributes to local and national guidelines on what clinical practice should be. So I would say try it, and I think don't be put off by not having an experience in academic or research the academic or research world before you apply. You know, really just try it and see if you like it. And even if you don't then spend your life in clinical academia, you'll still have learned something from doing a bit of research, and I believe your clinical practice will be improved from understanding a bit more about research, having to appraise it. No one dislikes talking about themselves, and particularly their research passions. So don't be afraid to just ask people if they're willing to just talk to you about how they got where they are and their research interests. One of the myths is that there's sort of one right time and one route into clinical academia, and that's not the case. And people bring different experiences and expertise depending on what stage they kind of join. And I think the other thing is that there might be one sort of person. I think research and the research community benefits from diversity and from people who have different experiences and different perspectives and different ways of thinking. And so if you don't see someone in your local unit, in your local department, who is like you doing research, don't let that put you off. And if you don't see someone like you, then maybe all the more reason think about doing research, because the research community will benefit from your kind of unique contribution. So there's no right time and there's no single right person for research.